Welcome to Free Flow, the Health Tech Law and Policy podcast, where we explore developments in health policy and help you navigate legal and compliance issues that affect your business. I'm your host, Dan Orenstein. On today's episode, I'm joined by Jonathan Bush, founder and CEO of Zeus Health and formerly co-founder and CEO of Athena Health. In October 2025, Jonathan made his first foray into elective politics when he launched his campaign for governor of Maine. Hey, Jonathan, great to have you on Free Flow.
Dan, I love that I'm free flowing with you. It's been too long.
Absolutely. I'm glad we have this opportunity to set this time aside. You and I have been dealing with the free flow of health information from different angles, and you pretty intensely with Zeus Health over the last few years. So, and I want to get into a bunch of topics on that, but maybe first, just tell me what's going on with Zeus, just in a few sentences. How's it evolved to where you are currently?
Well, Zeus seems to be rocking right now. Zeus started assuming much better performance of the sort of passive nonprofit interop networks, and so focus more on building workflows for people to use to build out, the components of longitudinal care that are different from the EMR components, which are most EMRs are pretty much centered on episodic, specific claims-based care. Right. And of course, we found that the data wasn't as good, or that there were giant gaps, and that no one even knew what the gaps were, and that in fact, the fabric was a mess. So we migrated Zeus back in about 22, 23. Mm-hmm. No, let's just be the stem cell. Let's be the complete, which is a huge word, always on, so gets complete as soon as it needs to. Fire native, so machines know and can use without a lot of giant AI compute to build workflows. API first, common patient record.
Yeah, and just a level set. So when you say common patient record, Fire, APIs, so how much are you kind of pulling real-time queries using Fire versus kind of steady state?
So we are trying to get to as close to real-time as possible. In fact, when you grab eligibility messages, you can get ahead of real-time. So you can say, hey, Dr. Jones, your patient, Dan, is about to see a cardiologist in 2 days, which is useful clinical information if you are managing someone's longitudinal experience of care. So as close to real time as possible. ADT messages come in, within minutes. Typically the emergency room or wherever they arrive doesn't actually produce a note within minutes, but to start looking within minutes. Obviously the worst case is that you see a paid claims, which are, 60 days after the person was seen, and you don't have that in the note. So you can go back and say, hey, what happened here? Why didn't you, Mr. Medical Center, share this record?
And when you pull this information, you work with EHRs so that they can see the information longitudinally real time in the EHR, right?
And we respond back to them with a much cleaner picture than they can get if we're not in their ecosystem. So over time, as the people who respond back, who request back from us, compare the output of a Zeus sharing experience and anyone else sharing experience, Zeus becomes...
Does the information you send back enrich these networks and third-party kind of aggregators data as well?
Exactly. Yeah. So, a lot of the Zeus customers are engaged in longitudinal care. They're people with episodes of care, lots of touches around a particular problem over a period of time, or a fully capitated primary care life. And so this is the quarterback is usually our customer, either the quarterback of the episode or the quarterback of and sometimes we get someone who's like, look, I don't want to give this person a blank clipboard. I need to get up to speed before I see them, and I'm only going to see them once. And so they pay Zeus once, but they then add, whatever they did gets added to the story of that patient when other people request back from Zeus. But the key is Zeus has built a common patient record, not a set of pipes. So we aren't passing you what we get and forgetting about it. We are aggregating everything we get, doing enrichment and conversion so that it's all a very reliable machine readable thing, and keeping it that way over time. And we have, many providers who don't necessarily know each other are reading and writing off of the same logical object, making that logical object better and better and better over time, faster, higher fidelity. The more uses, the more ways you try to use a record, the more complete and resilient and useful that record becomes.
Right. Awesome. Yeah, I want to get into that enrichment part in a bit, but first, let's zoom out a little bit. When you and I worked at Athena, we were dealing with the regional HIEs, kind of the emerging Commonwealth, care equality.
Right.
You mentioned the nonprofit. So maybe you could speak to where's that gone over the last decade and where are we now in terms of what you're seeing in the exchanges, which business models are viable and what, and so forth.
Yeah, I wish I could remember the Monty Python movie where our hero comes out of the castle and they're all the various messiahs. It's a chicken. The world will be saved by chicken. No, it's not a chicken. It's a
Right.
commandment. It's 23 commandments. No, it's 4 commandments. No, and everybody's trying to figure out. Mehmet Oz is, it's going to be a Mitt Romney, Mitt Gingrich. It's going to be a chip. We're going to have a chip. No, it's going to be an HIE, and it's going to be committees. They're going to be, no, it's going to be a QHIN. There are all these Tower of Babel types trying to drive their version of liquid health information. The
Yeah,
enablers, the enablement. Everyone agrees that it's insane that we spent, 50 odd billion dollars of tax money giving doctors
totally.
EMRs that then don't give you a complete picture of the patient. So there are lots of ideas. I think the one thing, though, the steel thread that runs through all the people with all the ideas and all the proclamations is good providers are making money knowing the whole story.
Hmm.
And so probably whichever mechanism, one way or another, one of these mechanisms will live. Commonwealth and care equality are great, such as they are. They're shipping CCDs of the whole story every time. So if you get a little tiny update to your record, one blood pressure added, you get the whole CCD again.
Jonathan, it sounds like you with Zeus are pretty agnostic about it. You just want the best data
Right.
from the best source,
Yeah,
best
I think that
curated.
over time, these things will be primordial fins. They'll die off, particularly the HIEs now. I think, we
Hmm.
don't even, I think there's 68 HIEs and we haven't even joined, 40 of them,
Yeah.
and aren't yet noticing anything missing.
So you mentioned the $50 billion, and that was federal money given to electronic health records, certified EHR technology providers to facilitate or encourage the adoption of
Yep.
EHRs and
Yep.
meaningful use and so forth. So the government did give the money. It clearly has a role. What is it about a couple questions. What is it about our system that makes it decentralized the way it is? And first of all, do you agree with that? And what is the federal government's role, in particular, having been a big financial sponsor of all of this?
Yeah, I think, we have we come at healthcare at an interesting angle because we are a free market society largely, even today, with respect to Mom Dami. We're mostly a free market society, but we also are a loving crowd that likes a safety net for people. And
Right.
healthcare is a market for services that also provides a certain safety net threshold. And the combination really makes it neither fish nor fowl, or both fish and fowl, depending on how you look at it. Obviously, the number with the Medicaid expansion, the number of people that are on government paid stuff is huge, but the number of people providing it that are government owned is very small. Almost all providers are either nonprofits or for-profits, but are not government clinics, with some obvious small, with very few exceptions. And so you run into this, one school of thought says lower the safety net so the market can work, and the other says get rid of the market so the safety net can work more cheaply. Look, let's do Denmark or something. 9 people in a country. They're all brothers and sisters. Like, could not be less like our problem. There's no, radical individualism there. Although now maybe there is, we're seeing these conservative parties
Yeah,
say,
very
I'm
different
tired of being
histories.
trapped. I don't want to be a socialist. Even while tea sippers in, America are like, oh, why don't we all just be socialists? My sense is there is a window, there's a lane for us to split the difference, to build really good free market products that have a threshold. And they're obviously not good below the threshold because the government's involved and you need to have the
Yeah,
ability to lose the account to make the product better. And if the
sure.
government's going to pay for the account no matter what, the product doesn't get much better.
We've got a unique system with the private delivery of healthcare and private payment and federal payment, this kind of hybrid system in the
Yeah.
US. It seems to me the way regulators in DC often approach this, they take these kind of forays into they know the private market is important, and you see ONC, ASTP kind of going out and getting information, doing
We want to
RFIs,
work with, what do they say? We want to work with
public-private
industry.
collaboration. But, like you said, there've been a lot of, primordial creatures that have come along the way from that in these collaborations. And what is, are we getting it right? Are we getting closer? And then you have the thing you attended last summer at the White House with, bringing private organizations together to attack interoperability. Where are we with this? Are we any further ahead?
I think we're dramatically further ahead. I mean, remember Athena Health, one of the days we won the class interoperability award, and it was a random smattering of CCDs that would show up in the back of some corner of AthenaNet, and you could look them up and read for days to get a tiny bit of information. I mean, just a disaster, but better than anybody else, whatever that means. So
Right.
we're in now we're 50 million record shares a week. I mean, it's more than FedWires. So we're in a very different place than we were, 5 or 10 years ago. It's the old Bill Gates comment, everybody's 1-year plan looks like shit, but if you stick with it for 5 years, you can't believe how far you came. And
Yeah.
it's absolutely true that interoperability, I mean, today, look, Zeus Health is, a living, breathing, industrial strength common patient record. It's just one, it's tiny, compared to what we need, but it's normalized in the sort of digital health crowd now as a platform to count on. That idea was alien. The idea of an API that you could read the documentation and then it would work and data would be there at all, even 5 years ago, was untenable idea.
I
So
do think it makes
absolutely, it's
sense
working.
to look back and see
Yeah,
what progress
I mean,
we've made.
I don't think I properly took a shot at your question. The big problem with the government is you get these great people who get their moment in the sun, and they think they've got enormous power because of the size of but we're a democracy and we're balanced, notwithstanding recent executive order frenzies. And they taste their own, they want to make a dent in the universe for the better, generally.
Sure.
And so they reach past if the government plays the role of boundary manager for the market, the government does great. When the government starts to then also play in the market, and I don't want to just be the referee, I want to be one of the teams, and I want to win, they start to work backwards against their mandate, and it starts to go badly. And then you have something that's got a primordial fin attached to it for generations.
I like that.
Can't get rid of.
I like that. Now let me you just reminded me of something that I wanted to hit, and that is, so this is like the government, your description is kind of the government as referee, but it shouldn't get too involved
Referees should
directly in the market.
make any plays,
Yeah. So kind of in the referee role. You mentioned executive orders, things that are coming out. We have the new ASTP HTI 5 version of the proposed regulation kind of on EHR and other health IT certification. It's taking a step back in terms of refereeing, arguably, or at least mandating certain parameters. It's reduced some of the clinical criteria, reduced some of the privacy criteria. Is it playing it right? Do you have a view on that?
I love doing less better. So it seems to me the government's emphasis is to get more people to play at something. And, the East Room, and they couldn't get legislation or rulemaking done. But they just said, look, who wants to volunteer? Who wants to sign this big placard and,
Yeah.
and get to bask in the East Room, glory, and potentially, who knows what other executive benevolence will fall on those who signed you know, the special document as volunteers.
Yeah.
So I
Did
think
Zeus
there's an
sign
eager
onto the
desire to get.
placard?
Say again?
Did Zeus sign on to the
We
document?
did, absolutely. I
Yeah.
actually didn't sign it because I didn't get to that part of the ceremony in time.
Got it.
But
Okay.
our name is there with. I told Amy Gleason, just sign it. I don't mind.
Yeah.
I
Yeah.
can't do that. One of these days, I will get that piece of cardboard next time I'm at the White House, and I will sign it. We are happy volunteers to that. I think right now the tension is between the treatment use case and the individual access service. I think we are nowhere near complete on the treatment use case. We have lots and lots of people that either information block or information fumble or just are information incompetent. But it is accepted norm that one does respond to another provider when they're asked for data in the context of treating a patient.
Yeah.
That was not
Yeah.
normal, 3-5 years ago. It was technically legal, technically required after a while, but not normal. Still today, a huge percentage, 20-30% of data is missing. People don't respond, either don't know how, down low, don't want to, who knows? But there's already talk of, why can't this be in my mobile app? Why isn't this in my Whoop? Why isn't this? And the fever for that is authentic and real, he said, holding up his Aura ring, which is not connected to his medical record yet.
I've got my Garmin health.
Yeah, they are.
tracking.
Yeah, everybody should have. I mean, all this shit should be running off of your chart, just like it runs off your location and other things that the government open sourced over the years. We aren't there yet, and I hope we don't. I hope we complete the job of getting the treatment use case to high fidelity. Then I think it'll be very easy to make that complete record available to consumers. I think providers themselves can. But that's an example where if the government stays hunkered down on the treatment use case, starts to identify the people who don't respond, make a polite phone call, from the Office of Civil Rights, hey, you're supposed to do this, and then go to the next thing. It's just hard because whoever's in there today, they've we've only got what, three years left. Let's make a difference. Like the whole Obamacare thing, we got to get it through. Let's make all the sacrifices.
I want to drill down a little more on the information blocking piece. It's relevant because ONC, OIG have recently announced that they're going to step up enforcement on the information blocking rule. We've had that, cures since, I guess
2016.
almost 10 years now, 9 years. And there's been very little enforcement. There's a backlog of complaints. They've announced some very specific measures that they may enact, like, kicking you out of participation in MSSP and reducing MIPS payments and so forth, and penalties. What is your take on how enforcement should look? Like, is that the right way to do it? The way you were describing it sounds like it might be a little bit different.
No, I think that'd be fine. Complaint based, but people start to believe that they can complain. I think, frankly, the sending and receiving, everybody on both sides of this telephone, their handsets barely work. So, blaming a sender when the receiver can barely hold itself together, it's really just reaching a level of maturity where people have the internal infrastructure to even know how they're doing themselves.
Right.
I would attribute 99% of information blocking today to incompetence and ignorance, not, some sort of scheme to hold on to the data. Obviously, if you're a board of directors at a hospital and you were convinced to spend $1 billion on a MUMPS-based off-internet EMR, I bet you part of the pitch was you're going to own a lot of data and you'll make money on it. And all of a sudden, if people are saying, well, actually, I need this data from you for free, that's dismaying to owners of expensive hospital EMRs.
It is dismaying. As you said before, a lot of these organizations, vendors have received a lot of federal money. So do they have a responsibility to share the data or get a little more proactive or either in sharing or getting more insight into how they're performing?
I think in statute, it's clear that they do. It's not a moral
Yeah.
judgment. It's already there.
Mhm.
And I think, like I said, as people get their acts together and they identify people that are systemically not responding for any reason, the next step would be a sort of a complaint phase where people start to make complaints and the government starts to chase them down and no, no, I misunderstood. And just like the early days of quality measures, no, my patients are sicker, but it'll mature. And so I think we're sort of there. I think this year, I think 2026 will be the first year of some legit complaints going both ways. Someday the individual access service will allow individuals to say, yes, I want my life insurance carrier or my tort lawyer or my, whoever to have the data, and they'll be allowed. But today, that's not what falls under enforcement. And so, on both sides of the issue, there's going to be our first industrial sort of strength escalations.
Yeah. And so, I wonder how much of the impetus for more data sharing and interoperability might come from patients who are empowered with tools to make that happen. And my question for you is, do they have the tools now? Does that technology exist? And what can be done to kind of give the patients more control or involve them
Yeah.
more in the process?
It's always the case in healthcare. As soon as you count on the patient, you're a little bit screwed because you got a real barbell. You got the worried well, you got the people like you and me who know what our sleep score was last night or whatever. We're not
Right.
that sick. Like improved instrumentation of our records information will not move society's cost of care at all.
Hmm.
And on the other end, you have these poor lambs of God who are really sick, but they aren't all that engaged demographically
Sure.
in the pursuit. And so you really need to get data sharing to its maturity to pick broad-based, humble jobs that are done at industrial scale by the provider community. That is the only
Hmm.
way we will get a logical graph of the public health. And then, of course, we'll go from the cool new, think of you and me as the guys who bought the Tesla two-seater that ran for 23 minutes at 180 miles an hour or whatever, right? We,
Right.
we, we don't really need that thing, but we fueled the R&D to get a nice $40,000 family car that's all electric. Phenomenal, right? Same thing's about to happen on the data side. Once we get the core administrative backbone feeding records, updating records, and there's a lot of technological change that's going to happen in the
Sure.
course of bringing this to maturity. This idea of everybody lobbing these CCDs back and forth is an absurd idea. Of course, there will be a set of APIs. Hopefully, Zeus is the most popular of all.
That makes it user friendly,
Yeah, and
easy to
machine-friendly
use,
too.
both
Like,
for professionals and
yeah,
patients.
yeah. Well, then my point is once professionals are using it at an industrial scale, adding a consumer access layer, adding apps on top of that,
Hmm.
super easy
Yeah.
putt. I mean, we're trying to get people onto the internet, not get people from Microsoft Messenger to WhatsApp, getting a
And so
fully
do you have
complete.
confidence?
Mhm.
Do you have confidence that patients are going to adopt those technologies once they
I
become more
believe that
user
once we
friendly?
complete the graph, once there is a functional equivalent of a Google map or a Spotify library, a complete always on collection of it all, the friction, the coefficient of drag to add various views that consumers of different flavors might enjoy drops and you see an explosion. I don't think that explosion is coming in 2026.
Yeah.
It might come in
Yeah.
27
What's
or
your best
28.
guess? Yeah. A few years out.
I think this year will be the completion of that industrial strength graph. And maybe next, things, I would love for it to be done this year. I thought it was going to be done 5 years ago. You can see the scale picking up, but you're still not in the hundreds of millions. You're in the single digits of millions or tens of
Right.
millions of really decent records so far. So there's still
Yeah.
a lot of work to do to get a lot of FUD out of the engine. And then you bet,
And I imagine AI is going to be a part of that too. Part of it is just an elegant user interface, all the tools, the kind of consumer
yep.
facing tools that we all rely on every day. But really, I mean, professionals and consumers are really learning how to use AI. Now, if you can point your AI at a complete or pretty complete record as a patient, you might say, "Okay, yeah, I'm gonna use this if it
You
gives you
got it.
something
That's
useful."
it. And if you point your AI at your record today, you're like, "What? That's not me," So, today a really good use of AI is going through all of the attachments and PDFs that come clanging into your record,
Mhm.
through these CCD attachments and reading them and interpreting them and enriching them, making them something that a machine could read. And
Yeah. Tell me a little bit about what you're doing along those lines at Zeus,
yeah.
and, like, how you're using AI at that attachment and
Yeah,
data
so
layer.
The Zeus factory has sort of got three stations in it. The first is aggregation. Where was Dan and where does he go? Where is he now? Where has he been and where is he going? Okay, go to those places and get the data, right? So
Yeah,
just finding where a person has been and where they're going as quickly as possible and fetching what's there. That's the first thing. What you get is shite, it's a disaster. So the next
right.
step is to take the shit, lay it out on the ground, and make a pretty usable, discrete, logical object out of it. And we call that enrichment,
Yeah,
right? Convert it to fire if it's not there. Read the attachments, find the measures. Cardiologists rarely find the little field in their EMR to put in ejection fraction. They just dictate Joe's ejection fraction is down to 56% or whatever. Go grab that, map that to the fire resource. Now you see a graph of Joe's ejection fraction over years, and you can say how his heart disease is progressing, et cetera. And then the third thing is summarization, putting lenses on this completed object to do jobs. I'm an oncologist. I want to get up to speed on this patient I've never seen before. I'm a care guide, and I believe that this person can't afford the meds they're on. I'm trying to get them onto a new one. I'm a machine, and I'm trying to make sure people don't miss their appointments. I am a specialist in
mhm,
irritable bowel syndrome, and I'm trying to manage diet, stress, and clinical encounters into a perfect cocktail. Those jobs and those persona each need a different summarization of the same data at different times.
right,
That's a great
right.
AI use case.
Mhm,
Hey,
mhm. So
hey, AI, keep an eye on this. And if it looks like he starts splitting pills, let me know.
so both at the enrichment level and that summarization kind of
Yeah.
persona level, AI can be and is you are using it
Yeah,
to be
that's a good one. And
it's
I
very
even at
helpful.
the aggregation level,
Yeah.
getting a guess, does this look like we've got everything? Does this look like less than usual for this person with these
Mhm.
values? Is there is there a
What other
yellow
source
or a
can I
red
try to
flag
pull from
here
or
that
verify?
somebody's yeah,
Yeah. So there's a lot of talk about regulation of AI. It's been, talked about here. We obviously have the EU AI Act, which has taken its own approach, which is very EU-like. What is your view on, because at each stage, at each of those three layers, you're arguably adding value with the AI and maybe introducing some subjectivity and some steering into
yeah,
the data or, how it comes out in the
yeah.
persona view and so forth.
And I
What's
also
your
think
view on whether
old-fashioned
how
network effect, but yes,
yes.
AI as well. Yeah, everyone loves
Is
talking
it
about
is it
AI.
doing things like CDS or something that maybe should be regulated, or how do you think is the best way to make sure that's done responsibly, it's accurate, complete, fair, unbiased, all those things?
Yeah, this is where, does the government play? Does the government build the
Yes.
boundary, right? I mean, I think it sure is nice if your AI agent is reading something that is already clearly part of the chart and not reading
Yeah.
something that's not, right? I'm
Sure.
not sure I don't know if you have to make a law about that. The law is today the treater is a provider. Even if 99% of their work is done by an agent, there
Mhm.
is a person responsible for what that agent says with a national provider identification number and, by the way, malpractice coverage, who needs to be the sort of authenticator. So Verily Me does lightweight, nearly basically free primary care to 1 million people on Zeus. There is a lot of AI giving them support, but there are nurses and doctors that are backstopping that are
Right.
responsible for what that AI says. And they are doing checking and they are doing escalations and they are doing other things to ensure uh, that they don't cross the line and and have unmediated care masquerading as mediated care. And they've been disciplined about it. And that's what has to happen today. Now, you could imagine a day where someone says, well, I mean, you can Google your disease on the internet today and do whatever you want. So you could Google your disease and have AI help you. It's not treatment. Nobody can say that you were treated, but you can do your own research and not be treated and take care of
Right.
yourself
Yeah.
in a free
So,
country.
so I think what you're saying is it's really important to have a human, a practitioner in the loop to filter it through their clinical judgment and make sense of it, and before they
I don't know
communicate
if
with a
it's
patient about it.
important or not, but I know that the
Yeah.
way we solve the regulation problem is
Hmm.
if it's treatment, third party paid treatment, there is one.
Right.
And so whatever the AI does, it's the treater's responsibility to own that, just as it's their responsibility to trust the Welch Allen blood pressure cuff or any other device that's
Yeah.
messing around with digits in the course of care. There is a person who's accountable, who makes decisions based on the data they're presented, and that continues to be the case. But like I said, you can go get your own blood pressure cuff at home and take your blood pressure and decide whether to call a doctor. And I am
Yeah.
quite sure you
Yeah.
will be able to ask your AI fake doctor,
Sure.
what it
Sure.
thinks.
Well, we'll see how that all develops. One way it could develop is looking at the AI as a medical device involved in clinical decision support. That's kind of the way FDA's looked at a bunch of software assisted devices.
Yes,
And
and as you know, we fought mightily
we'll
against
see.
that at Athena when they wanted to make
Yep.
I forgot what the release rules are, but if you're FDA regulated, they promise to review each release, 85% of all your releases within 90 days per release. And we were doing one release a week. Like,
Right. That could slow things down a
oh
little
my
bit.
Lord.
Yeah.
I think the government would do well to see if they could figure out how to enforce the laws that they've passed in a consistent, reliable way. That'd be huge. That'd be a huge lift to the market.
It'll be fascinating to see how that develops, see if there's some kind of risk attuned framework that comes out. And it's evolving so rapidly now that
This is what I guess
industry
my point
taking
about the
responsibility could
FDA
also
is.
help.
I really hope the government doesn't decide to Karen people, to protect people at the expense of the innovation that's happening right now.
Right. Right. Interesting to see how that will all develop. So kind of what maybe project forward for a few years. Kind of what are the top 2 or 3 developments you see happening kind of like in terms of the industry making progress, and also how the federal government or state governments might respond?
I believe we are entering an era of common patient records. So I believe there will be a series of APIs, 1 or 2 or 5, I don't know, that are that replace. I think of the days when Steve Jobs would sell you iTunes for 50 cents each, one by one. And he was sure that people just wanted to own their own song. And they really did want to own their own song until their friend right next door had every song ever sung for $12 a month. So I see the emergence. And then you've got a real refactoring, because the established EMRs and other systems, CRM systems, are currently predicated on the claim being the atomic unit of information.
Mm-hmm.
And so do they die? Do they win and there is no longitudinal picture? Do they migrate over? Do you imagine a series of settings where you could say, look, I want my next gen to just show me whatever I've typed and nothing else? Or do I want it to show me what everyone else has typed, but in a different font? Do I want my next gen to store my own typing at all? Or am I fine just reading and writing off of the village, the national common copy that I've chosen? I'm on Visa, MasterCard, whatever it is. I believe we are headed towards a small number of medical record APIs that have no front ends, or aren't there for their front ends. And that we are due for an explosion of front ends. So it's not going to be like, do you want country or Western? Do you want your Athena?
But they'll be
Cerner,
serving off of all of the kind of core back ends.
Yes. And maybe some of them, certainly Epic has done a lovely job with care quality. I mean, certainly some of these EMRs may try to make a lasting play on the data side of this, but
Hmm.
I think the data play is a very different play going forward from the workflow play, from the compute play.
Yeah.
I think there's a lot of compute to do on
Fascinating.
the
Yeah.
data play, but it's a totally different industry. And once enough people build enough products on those APIs, then the old school is going to have to massively shit or get off the
I would
pot.
imagine data siloing kind of once people see the promise
Yeah,
of that, the
regulations
data
aside,
they're
once
going to want that, right?
yeah, this is my point. Like all this regulation stuff, once people are doing it, you don't want to be the guy not doing it, regardless of what the regulation says. You
Sure.
don't want to be the only guy handing a paper clipboard to someone to try to take a guess at what drugs they're on in 2029.
Right. Right.
When everybody knows, when everybody's phone has it, like it would be ridiculous. So
Yeah.
for the makers of software, I think they all need to see a path where either they make a very big investment in getting current and staying current and publishing a high performance API, responsiveness, or they need to pick one.
Yeah. So zooming out a little bit to kind of the big policy aims, reducing costs, improving quality delivery of care, those have been stubborn to make progress on, despite, I like when we started, when I started with you at Athena, there was like single digit adoption of electronic health records. So,
Right.
like to your point, we've come a long way.
Yep.
Where are we on the journey of hitting those big policy goals?
I mean, I think it's interesting, right? That we thought we knew what we were getting when we got everybody on an EMR. We didn't get that, but we did get something.
Yeah.
Remember, we had scanning trucks,
Yeah.
shredded like trucks that would show up at practices and run for days, scanning manila charts, to get people onto AthenaNet.
Hmm.
Today, when somebody goes from AthenaNet to Zeus, the data migration is in 3 hours and it's completely remote, just taking this and munging it over to that. Like I said earlier in this podcast about, I don't know how long it took us to get everybody on the phone, but it took
Yeah.
a lot less time to get everybody on email and took a lot less time to get everybody on text and took a lot less time to get everybody onto WhatsApp. It's like the entire world, once you're digital, the next generation comes much more quickly.
Sure.
So
Sure.
I see these next generations coming really, really unimaginably quickly compared with past generations.
Yeah. And just to get to that question, you think that can bend the line or move the needle on cost and quality, and that there will be ways to kind of accepted ways to measure it. And as a society, we might make some progress on that.
I think it has always been true that we have well within our grasp the wherewithal to cut the cost of healthcare in half.
Yeah.
But we're rich and we're busy, so we don't. Guys like you and me can't believe, the duplication and the waste and the
Yeah.
unnecessary surgeries and the unnecessary sites of care. Today, if we took everything that could be done in an ASC and put it there, that's 20 points right there on the total cost of care, doing nothing
Hmm.
else. We are dripping in opportunities to reduce the cost of care. Maybe now that we're at 39 trillion in debt, we tighten up. I don't know. But for sure, this idea of an always on complete record is yet another tool that can be used to dramatically reduce the cost of care.
Yeah. I also think that on the delivery side, same, maybe in a similar way to the fact that the availability of the data is just going to be too compelling to resist. You're just
Yeah.
going to want that complete
Right.
set. I think clinicians and patients are also going to be able to more clearly see what are the right protocols for my condition or subcondition or combination. And I want that, right?
That's right. And you point out a really important thing. A lot of the cost-saving innovations that we've enjoyed over the last 20 years have actually not moved on the cost curve. They've moved on the convenience curve.
Mhm.
Urgent cares and minute clinics are much cheaper than emergency rooms, but they didn't get adopted because they're cheaper. You didn't get $1,000 back when you went to the urgent care. They got adopted because they're convenient. And I think a lot of what this liquefaction of longitudinal data brings is enormous convenience. If, Zeus is running experiments on, rising risk,
Right.
you've got 10,000 patients, which one is the most likely to hit the hospital tomorrow? Once you know that and you start keeping people from hitting the hospital, I mean, that's nice because hospital costs a lot, but people don't like going to the hospital either. So if you suddenly send a paramedic in a Prius to their house the day before the, terrible event or whatever, or that you correct their meds or whatever. And we're seeing that already. You see companies that are killing it right now, Sprinter and Independent Living Systems and Ready Responders and Dispatch, and, where they're being used as a weapon system. Yes, they save money, but they're being used by people who aren't capitated also just to get that convenience, get those chronically ill people from hitting that horrible hospital mill.
Intervening earlier. Yeah.
Yeah. So I think
avoiding all of that
this stuff will,
inconvenience.
A logical graph of the American health will probably reduce the cost of care, but it'll also dramatically improve the intimacy and appropriateness of care. And probably until we go broke, that'll be why we do it. And we may go broke too. Like, we may be like some guys might be Macroning up there after Trump, I think we should move Medicare to 67 years old.
Maybe going broke will be a good, governance mechanism.
Necessity is the mother of invention.
Push us.
Yeah. The good news is we'll know what to do. It's like with the vaccine. Like, once you got an emergency, well, how fast was the COVID vaccine? I mean, we got a lot of gas in our tank in healthcare if we develop the urgency.
Yeah.
And
this
even
is
if
terrific.
We're doing great things.
Anything I missed? It's been terrific having you, Jonathan. Really fun.
I love it. I love talking to you anyway. And who knows, let a few people listen in, right?
Great topics. Keeping the content relevant, useful.
Well, I love that you're doing this, Dan, and I'm honored to be included.
Thank you. Yeah. Have a great day. And that concludes our episode of Free Flow. Thank you for joining us today. For more information, please visit our website at orensteinlegal.com and navigate to the podcast page. Remember to subscribe or follow Free Flow on Spotify, Apple Podcasts, and YouTube so you never miss an episode or update. This podcast is for informational purposes only, is not legal advice, and does not create an attorney-client relationship. Thank you for listening.